Good evening and welcome to Go Rural Virtually. I'd like to begin with an acknowledgement of country to say that I acknowledge that I'm hosting the Go Rural Virtually from the lands of the Turrbal and Yuggera peoples and recognise that this land has always been under their custodianship. I also acknowledge the traditional custodians of the various lands on which we study, work and live today. I pay my respects to elders past, present and emerging and celebrate the diversity of First Nations peoples and their ongoing cultures and connections to the lands and waters of Australia. And I extend to all Aboriginal and Torres Strait Islander people here tonight. My name is Meredith, and on behalf of Health Workforce Queensland, I welcome the health students, organisations and 13 speakers we have who've come together tonight to be part of Go Rural Virtually. I'll be your host for tonight, but I consider you all to be part of that process, and I look forward to us learning together. Collectively, we will explore the topic of mental health in the bush by listening to speakers who have a lived experience of mental illness and by participating in interactive discussions with mental health professionals and organisations using breakout rooms. We'll come together for a final session to discuss the importance of mental health and self-care, both professionally and personally. So to begin with, I'm going to ask Sharon Varela. Sharon's an experienced psychologist and academic. I'm going to ask her to set the scene by providing an overview of mental illness.
Thanks, Meredith. I'd like to acknowledge that I'm on Kalkadoon land and pay my respect to elders past, present and emerging. And also Inangai land is where I normally reside in Longreach, so I'd also like to acknowledge the Inangai people and the custodians of the Inangai land. I actually, if you can bear with me, I'm going to read you the WHO definition of what mental health is, because I think it's going to be the most important part of our conversation today if we can have a look at what mental health is versus what mental illness is. And so WHO says that health is a state of complete physical, mental and social well-being and not merely the absence of disease or infirmity. Concepts of mental health include subjective well-being, perceived self-efficacy, autonomy, competence, intergenerational dependence and recognition of the ability to realise one's intellectual and emotional potential. So when you have a look at a definition like that, it's so holistic. It's telling you that your mental health is more than what's going on in your mind. It's a combination of many, many factors. And so social capital, lived experience and all those things play a role in physical health outcomes and not just mental health outcomes. Mental illness is a diagnosable condition. And I really don't like that we call it mental illness. It's really neuropsychiatric conditions that are diagnosable through, you know, the ICD or the DSM. It doesn't matter what manual you use, but there's a set of criteria that you follow. And there's a set of factors and thresholds that people have to meet to be diagnosed with mental illness. And the reason why it's important to separate the two is because you can have a diagnosable condition and still have good mental health. If that diagnosable condition is well managed and you have all the supports around you, you can enjoy mental well-being and mental health. And so that, I think, Meredith, if that's all right, is the platform I'd like us to launch tonight on.
Thanks, Sharon. So just, I guess by way of assisting the terminology that we use, like I often refer to mental illness, but what would be a more acceptable phrase or term to use?
I think mental illness is fine. It's more the confusion that it creates because we talk about mental health, we talk about mental illness, and people think they're interchangeable. It's a real big mouthful calling it neuropsychiatric. So, you know, we just need to be clear that when we do talk about mental illness, we're talking about no different than talking about a heart condition. it's a diagnosable condition that has to meet certain thresholds, whereas mental health is a more general term that we can discuss more openly, that allows prevention and intervention and support.
Okay, so it's more about understanding the distinction between illness and health. Great. So another aspect that we want to sort of talk about tonight is that, you know, and interestingly, rural and remote mental health statistics aren't that different to urban areas, but mental health is certainly a bigger issue in the bush. And to shed some light on this, we're going to turn to Dr. Ebony Vandermeer. Ebony is a rural generalist with advanced skills in mental health and addiction medicine. I'd just like to turn to you now, Ebony, for your thoughts about that.
Yeah, thanks, Meredith, and welcome everybody tonight. It's my pleasure to be here with you. I guess I'll start by acknowledging also the traditional owners of the land in which I work, which is the Guuga Yimithirr people, and their elders past and present. Thank you for the beautiful welcome to country, Meredith. I think one of the reasons that mental health is a bigger issue in rural areas as opposed to urban areas, not when you look at the statistics would suggest that the rates of illness or issues with mental health are similar, but there's a number of reasons why I guess it's a bigger issue for rural and remote places than it is in the city. And part of that, I think, stems from a lack of health literacy and also a lack of access to care. You know, there isn't a psychiatrist that you can just book in with. There isn't a psychologist often that you can just book in with. There's not many well-being kind of services in rural places, rural and remote places. In some places there's nothing. In some places there's really great services. It's very variable. And actually, if you look at the number of psychiatrists and mental health professionals per capita, in the difference between rural and remote and urban centres, it's very different. So the access is really not there, and people turn to their GPs. I think also there is this sense of stoicism and stigma and shame that's a big thing in small communities. There's not that sense of anonymity when you're walking into a mental health service or you're walking into an alcohol and other drug service that there may be in bigger centres. And similarly, I think that there's a big influence on, I guess, someone's socioeconomic status and their ability to kind of have a place in their world that they can actually go and get that help. I work with a lot of patients who identify as Aboriginal or Torres Strait Islander, and you know, I guess the thing that I notice a lot is that people are struggling just to have some sense of stability in their lives, housing, food security, ability to kind of get the kids to school and that kind of those basic human needs. Some of that, I mean, that's not different necessarily to the city, but, you know, worrying about your mental health and doing things proactively for your mental health in that kind of context is well down the list of priorities for a lot of people. So I think it's complicated, but I definitely think that there's a big gap in rural and remote areas compared to urban areas in terms of mental health. And also then a big opportunity for health professionals in rural and remote to provide really amazing services that are holistic and able to provide that kind of, I guess, accessible and acceptable care to their patients in this space.
Thanks, Ebony. There was just a comment from one of the students. Just let me get that up. It sounds like there would be a lot of underreporting on the numbers of people experiencing mental health issues also.
Yes, and I think that's across the board. You know, people that don't want to have a mental illness because there's so much stigma attached. So yes, I would agree.
Yeah, and I guess it also speaks to many people wouldn't necessarily recognise that they're struggling mentally. You know, like
Yes,
given all the factors that you just outlined, when you're just trying to deal with food security, accommodation, employment, keeping your family together, you're not necessarily going to identify that you're struggling with your mental health.
Yeah.
I want to now just bring in Dr. David Walker. David's practices in Longreach. He's a GP, and he's also Executive Director of the Medical Services for Central West HHS, and as well as David, Dr. Tim Driscoll, who works with the RFDS. Tim is a clinical psychologist. Tim and David, can we just explore a bit, please, the barriers that rural and remote communities face accessing mental health services in a bit more depth, please?
Yeah, thanks, Meredith. I'm actually going to dob Tim in to start here, but I might, I suspect I can do, thank you for your acknowledgement of country earlier, Meredith, and the other speakers have already touched on it. Tim and I are both speaking from Inangai country. Based out here in Longreach in central West Queensland. Tim, I might give you first bite of the cherry, and then I'll add to it.
Yeah, you can fill in all the gaps. I'll leave David. That sounds really good. Look, I guess in some ways, the barriers are the same, and in some ways, but they're exaggerated. I guess if you think about stigma for mental health, I think that's an issue in other areas as well. But if you imagine a smaller town, everyone knows where you're going. So if you do have that concern about a mental health condition, you may be more hesitant to go and seek support. The other thing is access to service. So a lot of towns have access to mental health service, but they certainly don't have the same selection of services. So there's not the same degree of choice. Obviously, telehealth is opening that up a fair bit, and there is various moves into telehealth. We're still a long way away with telehealth, and I mean I think it's got a future, obviously, as part of the package that we deliver mental health in the bush. But I guess there's a bigger challenge with that as well. So if you imagine you're in a city and you want to use telehealth, you've probably got a lot better internet connection. So even sitting in the middle of Longreach, it's very common that the internet will sort of go a bit fuzzy in the middle of a session. Look, which is fine in a meeting, but not when someone's really, really distressed. It gets really difficult to provide really good emotional support when there's technical difficulties going along. We're a long way away from reaching a point where that's a seamless sort of experience for people. So we are getting better in terms of access for people in rural and remote Queensland. I think one of the other issues, though, is that it's not always the same service that's required, depending on your community that you're talking about. So you can bring in a city service, but it might not be actually appropriate for the community you're servicing. So there's also cultural considerations as well. I mean, if you look across the the state of Queensland, there's broad communities and broad cultures. So sometimes there's services available, but are they fit for that community? And probably one of the biggest differences I've really noticed, and I think this is not just mental health, I think it's health in general, is that people wait a lot longer to go and actually get medical help. And I think that's sort of exaggerated when you see the mental health space, is that people just wait a lot longer to go and get help. So I guess that's sort of the main things I've noticed. You don't have the same options. But I think also, depending on your community, there's also that sort of stoic approach where people will keep going with things until they get really bad. And that has really bad outcomes for both mental health and physical health. And I guess I can hand over to David to fill in all those gaps for me.
Thanks, Tim. I don't think there's too many gaps. I forgot to say hello, everybody. I think I don't want to be too staid on here tonight. It's really great to see so many faces and really have a chance to talk about why we all love working and living rurally in many cases. It's great to be here. So look, I think between Tim and Ebony really touched on many of the issues that people face, the kind of intertwined issues with health literacy and also what they call rural stoicism, which is that kind of, not presenting until, you think it's going to get better, it's going to get better. I'll go at some point, but I'll come good, and you never actually do come good. And I think the other intertwined thing is this issue of stigma, which of course we've all heard about, but there's a real fear of that health professionals might either, well, usually inadvertently breach someone's confidence. There's a real fear that people might actually give away the game, so to speak, and even you know, in Tim's case, which is the RFDS base, which is just up the road from my practice. You know, some people even told me that there's just a kind of a fear that someone might see them walk in there and might give away that they've actually gone to the RFDS to seek help. So it's a real shame that those things exist. I think we've touched on issues of access, and tied in with access is just pure geographical dislocation. So just being so far away from not only services, but also your supports. In many cases, people might come out here in occupations like the police or education or other or departmental kind of jobs where they actually get removed from their families and their supports. And so that just pure geography, like the closest town to Longreach is 100 k's and the closest kind of tertiary centre is 600 kilometres away. So people can be really geographically isolated from those around them and also from supports. And I think that's really, between the three of us, it's really all things I see as kind of major issues with as barriers to people accessing care.
Thanks, David. I'm just going to read out a couple of comments that have come through while you were talking, David. It was just a comment in response to the telehealth. Do people prefer face-to-face, or is the anonymity of telehealth a bit better for people in smaller towns? And Ebony responded, I think it depends on the person. Seeing both would work for people who need care. And then Izzy added, absolutely agree. I think patients appreciate some form of contact versus not. And Sharon, I agree. Telehealth is a personal choice. It's not either or, but another option for access. Izzy then responded, we were always advised to aim for face-to-face because you can't assess their mental state fully without that video input. So thanks, everyone. That's great. It's great to have your comments, and please, I do encourage students to jump into the chat as well. Add your comments and questions. We'll get to them as soon as we can. We're going to move on now to the two speakers who both have lived experience of living with mental illness. So we're going to hear from Lynn and Izzy. And I'm going to introduce Lynn firstly. Lynn is a cattle farmer from Baralaba in central Queensland. The property also runs a family farm stay business, which has also hosted our Grow Rural program students since 2017. So over the course of the past 5 years, we've become very close to Lynn and her family. Lynn lives on the property with her partner Carl and her 78-year-old mum Olive. Olive was diagnosed with Alzheimer's 5 years ago. But Lynn, I'd like to start tonight's your story, please. How would you describe life before your diagnosis?
Well, I thought my life was going pretty well. I did worry a lot about, things about my parents and about the business. The business was growing, but I also thought that was normal. The rest of my life was fun. I had a great childhood, no great trauma, was always fit and healthy, had friends, had hobbies, had interests, life was cruisy. Hadn't been to hospital even much before. And then, I got quite stressed when Dad had a stroke in 2018 and didn't realise how uncomfortable I was with hospitals, and I got all shaky and nervy when that happened. And Carl just said, come home. I didn't have to deal with it. I just ran back to the farm and had a big nap and all felt better.
So, as you said, your dad, Peter, he had a stroke in 2018, and I remember we were there with the Grow students, and he so kindly, subjected himself to us, talking to us about, his experience of having a stroke, and you spoke about how it felt for you, and but something happened for you in 2019. What was that?
So in 2019, 3 weeks after my father died, I was diagnosed with bipolar 1. So yeah, Dad was in Baralaba. We took him into the hospital and he stayed there for about a week, and then they transferred him through to Rockhampton, and I knew it wasn't looking good. And I rang my siblings, and by the time that they'd come, I had been missing a lot of sleep, which is not me. I've always needed my sleep. And yeah, I just could not sleep. I actually even rang Lifeline and I was like, I can't sleep. This is not good. And the man talked me through and helped me try and get to sleep. Whether he recommended to me that I should go to the doctor, I don't remember that, but I didn't. And yeah, when Dad, my sister and Carl took me to the GP for just before the funeral, and they gave Carl a tablet and he tried to give it to me and I pretended I took it and I didn't. And then he made me take it, and I think it was a Valium of some description, Carl says. And but then things just spiraled out of control, and yeah, I was manic for about 3 weeks before, by the time the GP could get me an appointment, because we wanted to go private, and whether that was the right thing or wrong thing. I think I drove Carl crazy because I was crazy. Yeah, we got there and I got into the appointment in Rockhampton, and Carl was just telling me that he drove the car at 80 kilometres an hour because he didn't want us to be early and me do a runner or something. So we just poked along really quietly until we could just get to the appointment. I do know I turned when you wait right in the waiting room, there was a TV, and I just thought I had the right to go and turn that thing off because it was annoying me. And yeah, went in and talked to the doctor. She was lovely, and she just diagnosed me. It felt like just like that. Medication for the rest of my life.
Has the medication helped, Lynn?
Yes. And more so, the medication I took initially was, which I was, and I still sometimes call them the stupid tablets. Oh God, I have to take my stupid tablet. But for me, I have been taking Epilim 500 since the day I was diagnosed, and I haven't had another event. So must be working. And I have taken the sleeping tablet. I've had to take Mum to the hospital in Rockhampton, and I couldn't sleep well. And I was like, oh, I've got to take those stupid sleeping tablets. And then I broke it into like a quarter, and it didn't really work. And then I had another quarter, and I didn't really work. So then I had to have the whole one, but I didn't really want to have it because I wanted to wake up well enough to take Mum to the doctor. So the medication works. I believe in it. I think it's the only thing I have to do. And I knew some people that have no longer alive, and they had bipolar. I didn't know that at the time, and they didn't take the medication. They're gone. So I'll take those drugs.
Yeah. Do you remember, when you talk about being manic for 3 weeks, what that was like for you? Like, are you able to do you have a memory of that?
I thought you'd ask that, so I tried to write it down. I've actually been trying to remember what happened for the last 2.5 years. And I've written it down because this is what I can explain 2.5 years later of what I remember. All I can say is that I lost touch with reality. I no longer knew what was real and what wasn't. I remember my fingers twitching. I remember having the strangest dreams, like nightmares. And I'm thinking back, I can at least remember 40 different moments or scene that were happening, and I'm not sure even now if they were real or not real. I know they weren't real, but they were like little snippets of my life with this exaggeration to it. And at the time, they felt like a significant, important sign or signal or message I was receiving. So I liken it to like the movie Alice in Wonderland, when nothing makes sense and it's all very strange and disturbing. And I definitely felt enlightened. I definitely felt wired, and I definitely felt terribly important. But at the same time, I was paranoid and annoyed and trying to save the world.
Yeah.
So it's really hard to say that without sounding and helping it make sense. But really, when I tried to write it down, I couldn't. And that, I suppose, is what really why it's an illness, because you're too ill to even comprehend it 2.5 years later.
I think you've described it perfectly, Lynn. I think it, that gives everybody a greater sense of what being manic, would feel like. Thank you for sharing that. George's just George's posted, "Hi Lynn, it must have been so confusing experiencing this, especially as you felt so fit and healthy previously." And others have just wanted to say thank you for sharing, Lynn. This is very valuable. And Lynn will be in one of the breakout rooms that we're going to later, so there'll be an opportunity to ask her further questions. But we'll move on now to our next speaker, Dr. Izzy Chowan. Izzy is a psychiatry registrar who has a unique story to share. Izzy, given this is primarily a health student audience, perhaps you could start your story at a time when you were a student.
Hi everyone, I'm Izzy. So I am a final stage psychiatric registrar, but I'm currently on a year break in training because pretty burnt out from working up in Queensland Health. So now I'm actually down in Tassie doing some locum work and being much happier. So my story actually began probably when I was a student. So I trained in James Cook Uni. So I did a whole bunch of rural placements, almost became a rural GP, but fell in love with ED and things like that. So when I was a student, I was quite unwell, but I probably didn't have any insight to it. And I wasn't unwell enough to go to hospital, though a lot of my friends would say that they were really worried about me. But I'll explain later. But essentially, I was hypomanic, and it was like 2 weeks before my medical school exit exams. And I had not slept for like a week. I flew down to Brisbane to meet someone I never knew. I disappeared for a week. My friends couldn't find me, things like that. And I blew through a lot of money as well. And at the time, I thought it was really funny. So I got better. Obviously, I passed my exams and I moved on with my life and I entered intern year. So this was probably like 2 months in. I had always wanted to be an ED physician. I was really excited about my placement. I was in Mackay. There were a lot of issues, I think, but at the time, I think I was already depressed, but I was in denial. So I never took any medications. I mean, I always thought like, everyone could do it. Why couldn't I? I saw a lot of my colleagues struggle. So I saw things like in the ED, one of my colleagues would just break down crying and everyone would just not do anything about it. They just went on and continued working. And I was like, that's not good. Things like that happened often. And essentially I reached a stage where I wasn't sleeping. I think I didn't sleep properly for like 2-3 months. The aircon broke, so I definitely didn't sleep more. I stopped eating as much. I became actually quite suicidal as well, but they still went to work. So that wasn't good as well. But I think the main thing was I realized how unwell I was when it was late. So I remember responding to an emergency call, and essentially I had known the patient for 2-3 weeks, and all the nurses were like, Izzy, what do we do? And I just looked at him and I didn't know who he was. I didn't know what medications he was on. And I knew then, I was like, I need to actually go see a doctor for this because I lost my memory. I had no concentration. So it became so bad that I ended up in hospital. I was there for 2-3 months. And because I was in Mackay, there were no private hospitals. I actually had to go to Townsville. And it was really scary because it's such a small place. Everyone knew everyone. So I was like, oh my God, it's so embarrassing to be in hospital. But turns out that actually one of my friends was also in hospital. So like she didn't know I was in hospital. Obviously we met each other in hospital, but it was also like strange, you know, but the time in hospital, I was there for about 2 months, 3 months. So at this point, I had not worked for 4 to 5 months. So I was really broke. I wasn't sure if I was going to practice medicine again because my concentration was so bad for like 2-3 months. I couldn't do anything. So little things like what I ate for breakfast, I actually didn't remember if I ate it. So I would eat breakfast and then go up to my room and be like, oh, I think I have to eat breakfast. And then the nurse would be like, oh, you had breakfast. And I was like, no, I didn't have breakfast. And it was just a really scary time. So every day was like this black hole of like hopelessness. And it was really terrifying. And I think I only got better near the end. And I remember the day when I could read again. And I read like 50 books in like a week. But yeah, so it was a really difficult time, but I probably left the hospital still a bit in denial, being like, okay, look, I think this is like stress, maybe like depression, but I was actually diagnosed with bipolar disorder. So it was only the year after that I got another psychiatrist because I moved down to work in Mackay again, that he was like, you should probably report yourself to APRA because then it doesn't look bad if someone reports you. So there's all this uncertainty about the APRA because nobody wanted to talk about it. So yeah, so now I'm better. I would say that I'm really grateful for the experience because my quality of life is so much better. I mean, I'm not as creative anymore because I'm not as sad. So I do understand some patients who are like, oh, doctor, I'm an artist and I don't want to be on lithium. And I mean, I feel their pain, but I always tell them, you know, you may write good songs, but you'll be dead. So I don't know, they like it because I'm honest about it. But essentially, yeah, I'm not as creative anymore. And I do understand people who struggle with the idea of having to take a lot of medications because I have side effects from it because I'm on lithium at the moment. And I always need to take quetiapine for sleep, which is annoying as well because the first thing to go is sleep. And I used to be one of those younger people who used to party for 24/7, not sleep. And now 9 p.m. I'm like, I think it's bedtime. But other than that, I also keep well by exercising, obviously not too much, but it also helps keep me healthy. So yeah, exercise, medication, lifestyle, having really good supports. And also, I guess in hospital, I addressed a lot of the relationship issues I had with family, with toxic friends, with all these things. I did a whole bunch of therapies that also help. I do a lot of mindfulness stuff as well. So all those things in conjunction, and also I really love my job. Now I'm doing psychiatry as a career, and I really find a lot of value in helping other people. So I live a much more fulfilling life, really, even though probably that year was complete hell. I would say that I'm better for it. I have made a lot of friends in hospital, funny enough. But yeah, so I don't know. I feel like it's not a strength. I think it's like, what's the right word? It is a blessing in a way because I think you get what patients are feeling. I think a lot of the discussion with mental health that patients are really worried about sharing some of those thoughts is that they feel that if they say they're suicidal, you'll send them to hospital. So I always say, you know, we keep a lot of suicidal people in the community all the time. We just have to think about how to keep you safe. So just because you say you want to kill someone, you want to kill yourself, it doesn't necessarily mean that you're going to go to hospital. Because I think that's what also there's friends that I used to have who didn't know the illness, who didn't understand. They get really scared whenever I share something, you know, so I stop sharing because it's like, well, if I mention something, they're like, oh, are you manic? If you're spending this money, oh, are you manic? You know, and it's not just like that. It's about understanding them as a whole person, having that conversation, being honest and being like, oh, okay, I think you're really unwell now. You know, And I really appreciate when my psychiatrist, my friends, my partner, you know, people at work who are honest, they're actually more helpful rather than in a coercive way, because I find that the people who do best with their mental illness, no matter how major it is the idea that they have control over some part of or most part of their lives. But yeah, that's really where I am now. Yeah, so any questions really?
There's a question, Izzy, did you work with any occupational therapists as part of your recovery?
No, I didn't actually. I actually didn't even have a social worker. It was a private hospital that is, I think they were quite new. So I had to maneuver my own financial difficulties myself. They didn't even have they did have a psychologist. Yeah, I remember that. But no OTs really. But that would be a good thing to think of as well if my memory like didn't improve. Because a lot of bipolar illnesses, I think they do have a cognitive impairment and decline. Yeah.
And there's another question from Hannah Kay. Thank you for sharing, very inspirational. How did you find AHPRA's response to you declaring your MH diagnosis? Did you find it easy to discuss with them and navigate the process?
So yes, just my advice would be, I think AHPRA comes down really hard on doctors. I don't know why, but just doctors, I know that for sure. So it's always good to disclose that yourself first, but also make sure you have a good psychiatrist who will say that you are stable. You know, there's no point having a psychiatrist that while you're unwell in hospital and the psychiatrist is saying, oh, she's not fit to work. So once you do that, they'll ask you to report to them. So once the psychiatrist will say, oh, you are stable, you are good to work, there are no issues with the practice, then AHPRA will ask you for yearly reports from probably the same psychiatrist. So I would just get on top of that because I was a bit naughty this year. I was a bit late because I was moving, things like that. But my psychiatrist was amazing. He just wrote another letter. He's like, oh, Izzy, I'll call you over the phone because you're fine. And then he just did a letter. But yeah, AHPRA takes it really seriously. So they will put conditions on your licenses if they, get a patient complaint, even if it's vexatious. So it's just important to report yourself to AHPRA because I know there's a few cases. I think there was a GP down in Melbourne who became really unwell, refused to accept any treatment. And then her GP put in something with AHPRA. And I think because of that, the conditions and everything, they're really punitive. I don't think they're there to help doctors, but that's my personal opinion. So you just have to maneuver it because they can be very unhelpful. But since then, I have disclosed it for the last 4 years and I haven't had any issues whatsoever, even though I have been hospitalized 2 years ago. They have no issues with you being unwell because it's an illness, right? You get unwell. The idea is that when you're unwell, you don't go to work and you don't endanger your patients' lives or your colleagues' lives, and that you actually get help and then you take leave from work. So they just want to see that. And then they just need the clearance back again from a psychiatrist saying, you are fit to work, there are no issues. I had a really bad psychiatrist in Brisbane. So that's why I went back to see my Sunny Coast one. He actually refused to write me that letter. And I'm like, okay, bye-bye. I don't like you. So there are some psychiatrists there. I don't know why. They're really reluctant because they're worried that if you ever make a mistake, there's a coroner's court. They feel that they may be at risk. But they're probably not your psychiatrist anyways, because they're not doing it for the benefit of your, So It's important to find a good one.
Yeah, thanks, Izzy. George has written, a silver lining is you have lived experience, not just theoretical. I'm sure your patients would appreciate it. The next part of the program is designed for you to have an interactive discussions in breakout rooms with the speakers, and it's a great opportunity to keep those questions coming in.
So yeah, my name's Wendy. I'll be your facilitator for this session. Just remember, if you have any questions, feel free just to voice them as you wish, or alternatively, you can place them in the chat, but we'd love to hear from you. So I might kick off with you, David, and ask how you personally help people with a mental health issue. If somebody, sort of walks into your office, what strategies do you sort of use to help them?
Yeah, so I think when I was thinking about a response to this, Wendy, I really thought about, I'll give you a broad structure for how I think about delivering mental health in rural areas. And then I guess there are lots of specific techniques that you can learn. Everyone would have heard of things like CBT and lots of other techniques out there, grounding techniques. There's a whole range of stuff that you can learn specifically, which I think you could spend many webinars doing on each of those. But if I think just to give people some broad things, so 3 simple things is, first of all, just listen. So just don't overthink it and just take the time to let the person tell their story. There's really a lot to be gained by just being patient and resisting the temptation to ask questions and resisting the temptation to interject and just listen. It's a really big thing. It sounds so simple. It's actually really hard to do in practice. There's a technique we do when we're teaching students and registrars is to have an egg timer, a 90-second egg timer, and actually see how long you can go before you actually get the urge to speak when you have someone in the room. It's actually really tricky. So practice just taking the time to listen to people and getting to know not just the presentation they've come in with, but who they are, their broader context, who's around them, what do they do? Like, one of my favorite things is to actually learn about people's occupations and actually learn what that means, what it entails, what are the pressures on them around them, what's their family supports, what's all the things that are going on in their life that actually lead you to the bigger picture of who they are and why they're presenting to you today. And remember, as a kind of a side note, we all hear about the kind of ticket of entry consultations. That they definitely happen. Be aware of people who are coming in for something fairly trivial sounding, but they're actually there to talk to you about their mental health, and be prepared to ask some of those questions. The second thing I'd say is that don't think you have to solve everything at once. And I guess this is coming from a general practice perspective. One of the beauties of being a GP is that it's the kind of long game stuff. It's about being able to work with people over a long period of time, knowing that you can see them again, knowing that you can actually chip away at problems, you can actually see them get better. It's actually really rewarding. I think you can actually get into a trap of thinking you need to fix everything then and there the first time you see someone. So just take your time. And I guess tied in from that is to actually plan. I never actually, especially with a new mental health patient, I never let them out of my room unless I know exactly when they're coming back. They've got an appointment in their hand. I've got a plan for what they're going to do between now and then. I write them down. I write down the plan, especially if someone's a bit is a bit fuzzy, if their actual mental state's affecting their ability to take in information. I get permission to contact the people around them if they consent to that. And actually just come up with what exactly are we going to do between now and then. And sometimes at the first presentation, especially if someone's acutely distressed, it actually might not be very much. We're not trying, as I said, we're not really trying to go from go to woe in one consultation, but it's really important to have a plan for where you're going to go. And I think as a fourth thing, a final thing, and I'm happy to take any input from my fellow presenters, is it's really important more broadly to know your network. So when you're in a rural town, know who's around you, know who does what, know what services are available more quickly than others, know what services offer what, and then again, more broadly, I guess, as Tim said in our introduction, that what's out there from a telehealth point of view, what kind of things might you send someone to more urgently, and then also know, your local mental health team. So if someone's acutely unwell and you need to get that immediate support, who's your go-to within the team to actually have those conversations. And here in Longreach, we've really worked hard on breaking down some of those traditional kind of barriers between community providers of mental health care and the Queensland Health mental health team. We really all work very closely together and get to the point where I could just pick up the phone, and if I call, I know that they know that it's important, and they'll always take it, and they'll always see a patient urgently. So they're my kind of 3 things. Don't just take the time to listen. Don't think you have to solve everything in one day. Plan what your next consultation is going to be like, and more broadly outside of that patient consultation, be aware of those around you who can help, because it's a team game, mental health, and the more you can lean on other people to help support the patient, the better. So that's my thoughts.
Thanks for that, David. Did anyone else have anything they'd like to add?
There is a question for David. David, does it happen often that people do not come back after their first appointment? If so, how do you handle this situation? That's from Hannah.
Yeah, there's two Hannahs. Is there two questions?
Oh, was it the same?
Yeah, no, there's two different Hannahs.
Oh,
There's
there's
rural
two
GP.
Hannahs.
That's okay. So I'll do that one first. Does it happen often that people don't come back to their first appointment? Not as often as you'd think. I think if I put a lot of time into kind of planning that next appointment, and really, I think I don't even allow the luxury, to be honest, especially if I think someone's at risk, I really don't even allow the luxury of saying, oh, just make an appointment on your way out. I actually either go out with a patient or I ring the desk and actually organise an appointment so it's in their hot little hand while they're leaving. I just try not to leave much to chance. And it's hard to get a GP appointment, but I keep reserved appointments that I use for people who I think need them. And so I'll allocate a reserved appointment to someone to make sure, especially if I think that they're unwell, as I said, to really make sure they've got that follow-up. And if they don't come, I usually call them. Well, I do call them, either myself, depending on how well I know them. I'll call them personally, or I'll have one of my practice nurses follow them up. And often it's just as simple as they've forgotten. But I always make sure I follow up those appointments, especially if I'm worried about someone.
That's great. Thanks, David. Anybody have any other questions while David's here?
They were actually similar questions. I just read.
They were similar questions.
Read the other questions. They're both similar.
Yeah.
So.
I like Jess's acronym, WAIT, wait, why am I talking? That was a great add in there. Thanks, Jess.
It's good.
That's great. Melanie's
got a hand up.
Got a hand up?
Yeah, so I was just interested in recovery-based approaches to mental health, and the access that you would have in rural setting to such things. I noted the lovely lady who was speaking to us earlier was sort of advocating for how much medication has been helpful and part of her journey. Having a lived experience of mental health myself, I found that that's been something that I've found a need to come off to be able to continue my journey. And I just wondered how much access there is for people in a rural setting to those recovery-based approaches to mental health, and providing, I guess, that conspiracy of hope that there is a future with mental illness.
Yeah, so it's a good question, Melanie. Thank you. I think as a starting point, it's probably important to realize. So as a clinician, my whole focus is recovery. So, and I prescribe far less medication than I did when I started, 15 or 20 years ago. It's about medication's definitely got a place. That said, it probably comes as no surprise that there isn't the kind of I guess the robustness of providers. There's not a huge, enormous range. It varies from town to town, depending on the town, with regards to formal providers of recovery stuff. Over the years here in Longreach, we've had art therapy, we've had people who specialise in PTSD, we've had people who specialise in kind of activity-based recovery stuff. The reality is that there is often a kind of a waxing and waning of who's at your hand. If you start with the approach that you want to see people get better and you want to see them get back to what they're doing, you can actually use the things around you, not just formal groups, but you can use things like the men's sheds, you can use sporting groups, you can use, in some cases, the church suits some people. You use a variety of tools around you to actually plug people back into society. So medication might get them some of the way, but I think, as you're kind of suggesting, it's not the be all and end all. You need to plug those people back into where they belong. It's hard if they don't have social supports around them, but using what the community's got, and that changes from community to community, is how I facilitate that recovery-based approach.
That's great, thank you.
Thanks, David. So we might just go to Sharon now. I think we might have touched on this a little bit earlier, but we often find the mind's treated differently to the rest of the body. Sharon, just why is it so important to take a holistic approach when it comes to treating patients?
I guess I'll take it from a personal practice point of view, and we can expand out from there because I think that might be more helpful. But we know from the research that, that physical and mental health is really interconnected and it's multi-directional. So we know that poor sleep can cause problems of physical health, but we also know that physical health problems can cause poor sleep. And we know that poor sleep is linked with mental health. So when you look at how that intertwines together, having that really secular approach to mental health makes no sense. And when Melanie was talking about recovery approaches are really looking at the whole person, the whole community, which is some of what David was touching on. So for me as a psychologist, some of my clients get a little bit taken aback because after they get to share their story, some of the questions I start to ask them is, how do you sleep? What's your diet like? Do you get out of the house much? Do you have people you can connect with? Do you have access to healthy food? So not just do you eat it, but do you have access to it? Financially, how are you going? Because we know that people that are struggling financially cut costs in ways that actually influence their health. And then the next questions I ask are actually questions that will lead them into David's room, which is, have you done a sleep study? If the right red flags have you had your vitamin mineral count checked? Are you low in iron? Are you low in other minerals? So is there other physical health things going on? We know that gut bacteria can influence mental health. So, is there something going on in the gut? And in that way, with David's conversation about we're all part of this massive big team, I think the more interprofessionally we work and the more we're willing to share our knowledge with each other across professions, the more helpful we are to our clients when they walk through our room. And as a private practicing psychologist, I have benefited from decades of working in interprofessional teams in public mental health or public health, or not-for-profits, and all of those experiences, I guess, have helped me not only take that holistic approach, but the next step that I take is I actually give all that knowledge to my clients. I don't feel that I'm the hero of their story or an important part of their story. I think as health professionals, we're barely a byline in your book. If we're lucky, we're a side note. So for me, our role is to have the privilege of walking that journey for a little bit of time with you, to provide you with that health literacy that will help you have agency over your own recovery. And then you don't need us anymore, and that's how it should be. And sometimes you might come back and then go ahead again, but that's okay.
Great, thanks, Sharon. Does anybody have any questions for Sharon? Here we go. Sharon, one from Hannah. Sharon, do you feel like there are enough professionals available to refer patients onto if needed, or does it happen often that patients have to travel far to see other specialists or do telehealth?
I actually provide telehealth, and I think the pandemic has changed that view on what it is. I have to say my early training in telephone counselling with Lifeline many moons ago has been one of the most beneficial skills that I've been able to draw from to do really good telehealth. No, we never have enough professionals to refer to, and the pandemic has added stress to a system that was already under stress. But the real issue in Australia is access to, health professionals when you don't have financial capacity to pay privately. The public system is under strain. It doesn't have enough funds to do its day-to-day. So they're seeing the top 10%. And even in the top 10%, I have clients that because they're mentally well, even though they have a mental illness, they're mentally well at this time. Mental health in the public system isn't holding them, whereas, 20 years ago, they would have helped them. And so they come into telehealth. And so those relationships that we have across professionals is really important. I do my telehealth through Rural Health Connect because Rural Health Connect hold risk. They have a lot of relationships with psychiatrists and GPs. If I have a client I'm concerned about and I'm not in their community, I can go back to that organisation and say to them I'm concerned, and they have local on-the-ground contacts. So personally, I think telehealth works if you have an umbrella organisation that's holding risk.
Okay, thanks. Terry Ann had said earlier, Sharon, I totally agree with the holistic approach. However, how much does it happen?
I think it happens more than we talk about. And I think it's an individual thing. I certainly know in Longreach there's a lot of interagency and interprofessional work that goes on. In Mount Isa, I'm involved in a pop-up clinic, assessment clinic, where we're working across agencies and we're supporting each other with the very limited funding that we have across different agencies. What communities don't realise is you've got one bucket of funding. So if a new organisation comes in, you lose an organisation because that funding, there's not extra funding for the new organisation. So it's more important for us to work together and have those relationships. When I worked in Metro, it probably didn't happen as much. We're all a lot more siloed. But I know that when I worked in private practice in Brisbane, I made a really big effort to have really good relationships with paediatric psychiatrists and paediatricians, because I was mainly in child and youth when I was in Brisbane. But that's really up to the individual. What do you think, David? I think you'd probably agree.
I'm probably biased, to be honest, Sharon, but look, yeah, as you probably could tell, there's a few of us who've worked together. Tim, Sharon and I have all kind of been in the same networks, and I just think it's the only way to be. I think as a GP, it's kind of, again, part of my mindset is just to look at the whole person. So I guess it's probably worth touching on, once, and Sharon mentioned obstructive sleep apnea, which is a really good point. But broadly, whether someone presents with a physical illness and then their mental health issues present during that time that you're dealing with them, or if it's the other way around. I've often got patients who are several years into their recovery journey, and then the kind of life catches up with them, heart disease and blood pressure and other things. And I think it's the kind of joy of being a GP that I get to help manage some of those things as well, and look at the whole patient rather than just mental illness per se.
Cool. Okay, Taylor's asking, in areas of remote, especially within Indigenous communities, how do you roll out the assistance of mental health, especially in times of COVID?
Wendy, I think Jess was going to be talking on that topic soon. Did you want her to jump in now and answer it, or?
No, we might leave that for Jess a little bit later if we like. We might go to Andrew's question. Andrew said, as part of the budget of the federal budget, the government are committing funds to addressing stigma and also building resilience and well-being of our children. Are practitioners seeing a rise in children's mental health? If so, what do you see as the main factor for this? COVID, lockdowns, school absences?
I am personally seeing adults through telehealth at the moment, so I might throw it out to the other speakers that are currently seeing children and youth.
I do work with a number of youth and students up here in Cooktown, and we are noticing an increase, particularly in younger teenage girls. A lot of the cases that we do see are actually related to school pressure or pressure to perform well. We do actually have a lot of people who also come in for, I guess, presentations which previously wouldn't have been really considered. So autism spectrum disorder or ADHD, these sorts of presentations which haven't really been considered before, but because there's a few extra services in town, people are being able to be connected, and there's now facilities available for these children to come in and access services, as well as runoff from domestic violence and also the vicarious trauma that's coming from COVID, the war in Ukraine, and yeah. guess that sums it up.
Yes. Okay.
Sorry.
Thanks, Jess. While we have you, we might, sorry, we didn't introduce you, Jess. Jess is a mental health clinician with the RFDS. You might like to do a brief introduction, and you might like to tell us what the difference is between Indigenous community mental health and non-Indigenous communities.
Sure. So I'm Jess. Hi. I am a mental health clinician. I'm a psychologist working for RFDS up here in the Cape. So I work out of Cooktown, and I also travel out to Wujal and sometimes Laura, who are neighbouring communities. So what is the difference between Indigenous community mental health issues and non-Indigenous communities? So I've had the privilege of working in both Brisbane, telehealth, and also up here in the Cape. Now, I guess we've covered a lot today about what actually happens, what impacts on services available. Some of the considerations that I think we often overlook or don't consider, and I know I had a bit of a moment where I had to take stock and, check what was actually going on and why my service was not fitting to start off with, because there was a few things that I'd overlooked, and some of those could be cultural differences. So individuals who live in a collective society often have a more here and now present focus. So when it comes to, I guess, scheduling appointments, we may not schedule in advance. When it comes to community, I will actually text the clients on the morning of, or I'll drive through the centre of town, big plastered signage on the side of the truck, and they will seek me out. And if we do happen to make an appointment further on in the future, they may not attend because their focus is more here on the now, rather than individualistic Western societies where we have more of a focus on a clock. So there's a few little things that we need to consider when it comes to applying therapy in certain areas. What else have we got? So as I think it was somebody mentioned before, that a lot of people are actually living in survival mode, and so there's a lot of difficulty around food security, housing, domestic violence, safety, trying to even get primary care. So we might need to think about if somebody's in a domestically violent situation in cities, they might be able to go out and to Centrelink or link up with other family. In rural areas, remote areas, you can't just go to Centrelink. So there's a truck that comes around up here once every 2.5 years to be able to go through some more intricate processes with Centrelink. And say the community that I go out to, Wujal, they would have to travel 1.5 hours to be able to get to Centrelink if that person is working, because they only work 2 half days a week. So it's not, some services are not readily available. And so we need to take that into consideration when it comes to safety planning, whether there's any family considerations where family plays a big part in a lot of communities, that you can't say no, that you have to be available, that your property is everybody's property. And so when we look at domestic violence safety planning, it could be that you plan to go to a family member's house, but that other person is also welcome in that house. So where do you go if that's not suitable for you? There's, I'm just trying to think of where to go. We've discussed about infrastructure, so having internet available, phone availability. Sometimes families often share phones, so being able to connect with somebody, trying to be able to have a telehealth session may not be appropriate. They may not have good signal. I know where I go, I often don't have signal for the entire day. Being able to connect with somebody who has given their phone out to somebody else in the family, you won't hear from them for days on end. And then so you have to look at, is there a risk involved? Do you have to try and connect with that person face to face? We've spoken about cultural values, family expectations. So often a lot of the presentations that we find in community, as I mentioned before, people are present focused, so they may only come in for a specific acute concern that they have at that point in time, and so you may not see intervention over long periods that you would do in, say, in Cooktown. I have a lot of people who come in and they will have appointments scheduled. In the future, we do specific therapy. We might go through eclectic practice. So we'd cover CBT, motivational interviewing, acceptance and commitment therapy. Whereas in community, it might be what that person is experiencing at that point in time, and they just want to have a yarn with someone. Other people might come in and we would be flexible with our therapy. So we may not be sitting in a room. I spend a lot of time on people's verandas. I spend a lot of time under the mango tree, and sometimes we'll jump in the car, we'll go on country, or go down to the wharf, and they'll go fishing. And so we'll have therapy side by side whilst they're actually engaged in an activity that is appropriate for them. In say Cooktown with the youth, I would give them something so that they're, you know, in these beta waves whilst they're actually engaging in therapy, to try and get them talking. We have to appropriately manage that and work around that in community, something that we may not have considered before. Does anybody have any questions at that, or am I just wondering if there's anything else to cover at the moment?
That was great informative information there, Jess. Thanks for that. So I might throw open to all our speakers. What approaches did you take to help someone who doesn't know they have a mental health issue, illness? And anyone like to answer that question? And then on the flip side, I might get Lynn to jump in and say, you know, what was her doctor's response when she walked in?
Just say that to me again. What did my doctor say when I went back and said? No,
well, yes, or just you didn't know. Obviously, you had a mental illness. Well, you didn't certainly know what it was. So, how did the doctor, you know, speak to you? What was the first thing spoken when you walked in the room?
Well, first of all, Mum and Carl went down with me, and when they called my name, they were expecting to go in as well, and I was like, no, I'm big enough to look after myself. You two have to stay out there. And I went in, and as David Walker beautifully said, this amazing doctor, she just listened to me. I felt like no one had been listening to me because my family was in chaos because we had a funeral and all that. And she sat very close. It's like she just came close to me, and she had this little clipboard, and she just listened. And I don't even know how long I talked for, but she just listened. And after she, you know, then she said, oh, okay, you've got an illness. And then I said, what did I say to make you think there's something wrong with me? And then she just said, you're grandiose and you're, you know, all over the shop, and I can't remember what else. And I was like, fine. She said, okay, we need to bring your family. And I was like, no way. And she's like, well, and she was very gentle. It was the most gentle I've ever been spoke to in my entire life, I think. And anyway, in her very sweet, manipulative way, I allowed Carl to come in, but no way was I letting Mum come in because she's got Alzheimer's. And I was aware enough to know, I was still well enough to know that I was still trying to protect Mum. And Carl came in, and he was very relieved that there was a label for it. And I was very pissed off that I was labelled with something that I'd never even heard of before. Does that answer the question?
Yes, it does. Thanks, Lynn. Sort of brings back to what David said earlier about listening. That's for sure. All right, so we might just take a bit of a turn. Oh, did anybody have any questions for Lynn at all, or nothing's particular for Lynn? Okay, might just take a bit of a turn. So I think we only have about 5 minutes left in this breakout room. We might go to Brent. Brent's the CEO of an organisation called Outback Futures. Outback Futures facilitates a unique approach to mental health outcomes. Brent, would you like to share?
Sure. Yeah, thank you very much, Wenda, and hello, everybody. Thank you for the opportunity. I think we're in a bit of a unique space compared to some of the more locally based practitioners. I'm not a practitioner myself, but our teams of people, so we recruit and deploy multidisciplinary teams of allied health professionals to remote and very remote parts of Queensland, so right through the central west and into the northwest of Queensland. I think that's probably the thing for me to talk about, maybe, Wendy, just in the short time that we've got, is just to unpack a little bit our model of what we call work in, work out. So we have teams of people that are recruited to a specific region. So we have, for example, we have a Barcaldine team, we have a Winton team, a Blackall Tambo team, we have a Longreach team. These teams of practitioners and coordinators and leaders within those teams actually work in those regions all the time, even though they're only in the region some of the time. So they work in the region in a clinic-based approach. They'll be on the ground a number of times each year, and then follow through consistently with telehealth. So clients will get to see the same practitioner, obviously, via a telehealth setup. And that's really something that's developed pretty strongly for us for a couple of reasons. We've talked a bit about the small town confidentiality and some of the challenges that people have in terms of accessing local services on the ground, and people more readily or freely sometimes access services that aren't in their hometown. And so that, for us, the telehealth is a really important part of that. But also for recruiting and retaining staff into remote areas. And you'll hear a lot, I guess, about workforce challenges in remote areas of Australia. And what we find is that people really find the work meaningful and really want to contribute and work in those areas, but it's always a challenge to get people to move to some of those remote areas and live there. So we see ourselves as just one part of the bigger health solution, not the silver bullet by any stretch of the imagination, but that's the model that we've used. And I think probably the other thing, just to say on our approaches, we really want to work at a very early intervention and whole of community approach. So we do the clinical work that we do is sort of at the low to moderate end of the mental health spectrum, but we also invest a lot of time and energy in community education, community involvement, whole of community wellbeing, working with communities to try and help them build their own sense of wellbeing and people that are prepared to invest in it. So it's that mix of actual service provision and whole of community sort of education and early intervention. And that's why we structure our multidisciplinary teams to include, OTs and speech therapists and learning coaches, so that they're investing often into some of those early developmental delays that children and families might experience. And we see that as an early intervention against mental health challenges in the long term. So if people can develop appropriately at an educational and social and emotional level, then they're not going to be as at risk of social exclusion, mental health challenges that you might often get in teenager and adolescent years. So that's probably enough from me, Wendy, unless there's questions or interactions there could be. But,
yeah, Terry's just asking, it's just jumped up, do we need to be on the ground? How do I gain employment or volunteer with you?
No, so we don't have any of our practitioners living in remote areas. Initially, when we started, when our founder kicked off Outback Futures, we assumed that we would. But as we've developed the model with feedback from bush communities and bush people, they say that they love it when we're there, but they love it when we leave, because they can still get us anytime, but they're not going to run into us in the IGA. So we're based in Brisbane. We have people who live in Canberra, Gold Coast, Toowoomba, Bundaberg, working for us, Sunshine Coast, Brisbane. So all across, the southeast, really. And we fly into those remote areas, and then we're there for a period of time, up to a week often, and then telehealth in the in-between times. So we'd be more than happy to connect with anyone who's interested in working with us in a student type capacity.
We've got about half an hour together. So I just want to start this discussion with a question to the students, I want to ask any of you to share an experience which shaped how you think about mental health. Happy for you just to start talking. You don't have to put your hand up or go into chat. Just, you know, anything that's happened in your life which has shaped how you think about mental health.
Hi Meredith, it's Georgia here.
Hey Georgia.
I grew up in Cairns and it was a really interesting experience. So obviously not rural, but when you're kind of in a smaller town, you notice that if you're a bit different, you stand out more. So that was really interesting, especially in high school, because you notice that even within yourself or your friends, if you're not like kind of really similar to everyone else, you seem more obvious. So I think that was always interesting and maybe a bit more pressure, I suppose. Like, as discussed earlier, you know, being in Brisbane or in a bigger city, you can feel a bit more anonymous or find people that have the same interests or learn about new things, but you might not have that access when you're from somewhere a bit smaller. So I think that's kind of why I've been interested in psychology, and that's why I'm studying it now. And yeah, I also found, you know, being involved with the Grow Rural and meeting Lynn and talking to her about her experience was really, yeah, kind of mind-blowing. Just you know, for anyone who's skeptical or whatever, it's, you know, this woman has always said she's been happy and healthy and lived a normal life, and then all of a sudden it just, you know, flipped like a switch. So that experience was, yeah, really, really good for me to hear. And yeah, you know, it can hit anyone, and yeah, we all have to be really aware of that, I suppose.
Yeah, thanks, Georgia. I think, you know, Lynn's, you know, public speaking's not a natural thing for Lynn, and, you know, she's always been so open with the students and has, you know, always approached us and said, look, happy to talk about anything. She just wants to, you know, for her story to help you as students to understand, you know, mental health in more depth. So is there anybody else that wants to talk about mental health, you know, as an experience that shaped their thoughts about what you know now? Or
I
can share something. Oh, you.
Sorry. So I'm Naomi, an ACU student, and we do community placements, and I work volunteer at a Emmanuel City Mission, and it was the first time I had interacted with people with mental health issues, and it is such a welcoming place. But I have never met anyone who is psychotic at the time that they come up to have a chat with you, or could be in a perfectly good mood and then something sets them off. And it's always really good for me, because just to see people as people, and these things that I've often heard about or you learn about in class, and go, they're a person, but they happen to have this thing, and I need to be informed. So I'm not the trigger, but my job is to care and just to, yeah, just seeing people as people.
yeah, I think that's a great point, Naomi. Thank you. Who was, somebody else was going to share?
Well, that was just me, Izzy, Mary. It's just me. I just had
just me.
Yeah, not just me. I had a story actually from when I was a student in JCU. So essentially, I was doing a mental health placement. So the backstory of this is essentially, before I actually joined the field of psychiatry, I actually, I'm going to be honest and say that I thought the field of mental health is a joke, right? Because I mean, as a student, you just see the worst cases, the ones that are really chronic, they never get better. So there's this patient, this is me trying to do a mental health stint because I don't know if I want to do it. So this guy came in, he was found homeless, alone, had no family members on his file. He had used so much substances that like he was so unwell. He came in literally with a shirt, and he had cut a hole in his shirt as a pocket, right? So when I was interviewing him, he literally put his cigarette in this pocket and it fell to the floor. And I'm like, oh my God, like what is going on right now? And so literally my consultant was like, oh, Izzy, call some family. And I was like, he has no family. And so for like a week, he didn't get anywhere. He didn't get any better. Anyway, so I was dealing with another patient, you know, talking to someone else. And this other guy comes up, he's had a haircut. He's wearing a nice shirt, and he's coming up to the counter to give us like this teddy bear. And I'm like, who is that? And they're like, oh, that's that guy. I'm like, what? No, that's not him. He looks completely different. He looks like a different person. And I think like that was the moment when I was like moved, because I realized that we're actually doing something. Like, I know it's such a weird concept, but it's like in public health, you don't see those things. But he actually like was functioning, and he could go home and, you know, be discharged, and he was wearing a proper shirt, and he was talking like he was functioning. I was just blown away. And it was just because he was psychotic and we treated him. And I think that was the moment where I'm like, I think this is the field that I want to do, because we actually make a difference to people's lives. You know, that, I don't know, like that was just the big moment for me.
That's a fantastic story, Izzy. Thanks for that. That's excellent. Tanya, you've got your hand up.
Sorry, there we go. My story comes from, I just started my nursing course, same thing. I wasn't aware, like, you know about mental illnesses, you know it's out in the community, but it's always this ooh-ah. And I started a job in disability, and I got sent to someone's house, and with no paperwork, nothing, and got told I need to go look after this man. Turns out he's a guy my age, on the outside, absolutely wonderful, big guy. He's over 6 foot, solid bloke, big. And I did not realize it, but he had schizophrenia. And it was, I've never dealt with schizophrenia. I've never dealt with any mental illness before then. I didn't have a family history of it. And so that was my biggest eye opener when he had an episode while I was there. At first, I thought he was just talking random things. And as the night's progressing, I started getting afraid, because I'm like, he's a big guy. He can do whatever he wants to me. And that's the moment that it kind of opened my eyes. I was like, hang on a second, it's not him. And from that moment, it's just been trying to get as much information and realizing, as the other girls have said, that it's something they have to go through. And he was apologizing profusely afterwards. And it kind of saddened me that he had to apologize. He didn't have to. At the end of the day, it was me that had to. The company should have given me better information on what was to expected. But yeah, that was my turning point in mental health, and yeah, studying nursing, but it's definitely something to look into.
Yeah, thank you, Tanya. Did anybody else have their hand up that wanted to share just before we move on? No, I want to flip the question around now. I want to ask the speakers. We've got Ebony, Tim, Sarah, Megan, Joanne, Georgia, and Izzy, who you've met. And I want to ask the speakers to share an experience or case that shaped how they approached mental health. Who would like to start?
I'll go, Meredith. Ebony here. I don't think it's a particular case, but I think it's just mental health always scared me. I'm a small person, and I am a bit timid naturally, and I get scared by overwhelming situations. Well, did get scared by overwhelming situations, and particularly like aggressive patients or demanding patients. I like to please people, so anyone that's not happy with me, that I really struggle with that. And I think for that reason, I was drawn to, I guess, to develop more skills in mental health, because I found that situation in an emergency department dealing with the behavioural emergency, or dealing with a patient in GP that's demanding opiates, or you know, dealing with someone who's really scared but threatening in their mannerisms and so on, frightened me. And I wanted to know how to manage that, and how to be able to communicate and de-escalate and calm and be present, do what I needed to do, but manage my own feelings, and kind of be more confident in that space. So when I did my advanced skill in mental health, that's what I focused on, is really around exposing myself to situations and patients, and dealing with difficult communication strategies and just really tough sort of, you know, the real nitty gritty hard stuff in mental health that you don't really get access to unless you're actually at the coalface in an emergency department or doing psychiatry, and or you know, out in community, really dealing with patients that are unwell. And that was just such an amazing experience. I had great mentorship as well, and great support and supervision in that. And I really learnt that often it's the way you say something, not what you say. And it's people just generally, they know if you are interested in them. They know if you come from a place of respect and care. And that was the fundamental thing that I learnt, that if you come from a place of respect and care and knowledge, so knowing what it is that, and being able to put yourself in the patient's shoes, also being aware of your surroundings and your limits and your need for safety, not only of yourself, but also your staff, and having those skills in a toolkit to be able to help anyone who walks in the door, not just someone with mental illness, any patient, anywhere, even not just necessarily patients, but your colleagues and whoever else you're having to deal with in your life. Mental health allows you that skill set, which I don't actually think any other specialty necessarily does or does very well. So for me, it was like opening this box of amazing skills that I get to use now every single day. And you know, I guess that's being privy to people's stories and being able to walk beside them in their journey. You know, that's something that's very special in mental health.
Thank you, Benny. That's yeah, that's very humbling to hear that. And I think, you know, it just shows such great personal courage to have faced you know, your fear, and then almost ironically to find out how simple it is, because you know, you come from a place of authenticity, so you don't have to have all the greatest theories in the world, but you have respect and authenticity, and that goes a long way. Thank you for that. Sarah, is it?
Hey, Meredith.
Hey.
I was just going to agree with Ebony. Like, I think mental health is just the best job in the world, and I think it's such a privilege to do what we do every day and see people's journeys and be a little part of that. And it's really nice hearing people's stories from being a student, because, well, it's quite a long time away from me. And I remember, you know, you get so desensitized to some of the stuff we see now, but I remember some of those people were really, it was quite confronting, you know, because you didn't really know what to say. And as Ebony said, it's about how you say it. It's about how you communicate. I always think that I learned how to be a mental health nurse when I worked behind the bar in Liverpool, you know, because it's just about communication and care and kindness and humour, and it's just such an awesome job.
Thanks, Sarah. Sarah's coming from Bali. We've decided that Go Rural Virtually has gone global virtually.
Gone international.
Yes. Jo started as she did a student placement at Yarrabah and has gone on to get a job with Kiran Yalamaka. Jo, do you want to talk to us about an experience or a case that changed things for you?
Yeah, absolutely. I went into Yarrabah Aboriginal community, which is about 50 kilometres southeast of Cairns. So, but to get there, you have to go over some ranges, and so it is quite separate from Cairns. However, the access is still there. I went in as a student, and I was told what particular therapies and practices that the mental health clinicians use in Yarrabah, and so I was all very gung-ho as a student. I was researched, I was armed with all my therapy and practices and everything that I learned as a student, and I went in and I had one of my first people that I was talking to was an older lady from the community, and she just didn't want to bar it. She just wanted to talk. And so what I learned from that experience was that I was going into it with my own agenda. And whereas I really should have just sat back and let the person I was seeing guide where they were ready to go, and then maybe implement some of that a little bit later. So my lesson learned was maybe put your own agendas and all that. I know it's wonderful learning, but just be in the moment and be led by the people to begin with, because she wanted just to tell her story. And the first session, we actually just spent the time talking about her history on the land and her generations, which was so important. And that's part of a really, really significant part of that practice in the community I work in now. So spending that time being still, listening, and not putting my agenda of I've got to do these steps in the practice that I thought was what we needed to do. So that was my lesson learned as a student.
Thanks, Jo. And I think that, you know, as you spoke, I was thinking about the Indigenous word for deep listening, which escapes me at the moment, but it's such an important skill. And I just want to also, I think this is an important question for the students to hear from speakers about, you know, what's the difference between Indigenous community mental health issues and non-Indigenous communities in your experience?
Well, from did you ask that of me?
Yes,
or was
and
that,
yes,
yeah.
both.
Sure.
Yes, Jo, because you have had you've got that lived experience of working with an Indigenous community. So, what would you identify as being, you know, the main characteristics of difference?
Yeah, so a lot of the work that we do in the community is place-based, and I feel that is very important for the community. So we have amazing services that come in, but they can come in for one day a fortnight, and I that may be across all rural or remote sort of areas. But to be place-based means that in this community, I mentioned in the chat that we have families that have one phone between a house, so you can't ring them up and say, hey, let's make an appointment, and if they don't answer, you work towards closing that case because you can never get hold of them. So being place-based is so important, because if we don't reach them on the phone, we drive out to their house, we do a home visit, we're there, we yell out of the car, hey, is such and such home? And they come out and there's a good chat, and we say, can I come pick you up tomorrow? We'll go for go out to country, and we'll sit and have a yarn. So there's that real immediate response, but also being able to do it face to face, which is super important, because there's not not that access to even a phone or car. A lot of the people. Or even finances where they can pay for petrol, so they can't come to us. So we're often in community. We also always travel with a local member as well, being a white person in community, just out of respect. And we know that that's what the community want, because we've asked them. And so that is another difference. I wouldn't just drive through community without one of the local people. We have 75% of the mental health the counsellors on our team are from community, so we often go out together. But yeah, so that's what I see as in the Indigenous community is a difference, is you're actually more proactive in going out to homes and doing that face to face.
Yeah, great. Thanks for that. That's a great overview. Tim, I want to ask you a question, because I think, you know, I know from working with the students for many years now, there's always been a great enthusiasm for the RFDS doing placements, but you know, as a clinical psychologist working with the RFDS, what just talk us through kind of what a day in your life looks like in 3 minutes.
Yeah, sure. I guess I mean, I guess maybe a better way of answering that question is to talk about what the clinicians do, because a day in my life at the moment, it's mainly management stuff, which is very, very boring to listen to. But essentially, look, we've got sort of, three main sort of approaches we look at. So if we started with Longreach, what we've got in Longreach is a spoke system, so based in Longreach and then servicing the surrounding towns driving out. So what that involves is very much the same as you'd see in any psychology clinic or mental health clinic anywhere, is that people will come in predominantly to that clinic and they'll get service, but it'll be a drive-in, drive-out model to sort of various communities in Central West. I mean, there is a little bit of outside that, obviously home visits and meeting in the park and that kind of thing as well, but it's very much a therapeutic service. So that's what that's sort of focused on. And then out of Charleville and Mount Isa, we've got the remote wellbeing service, which is our flying service essentially. So wherever the RFDS sends planes in Western Queensland for primary healthcare, we now send a mental health clinician. So they're flying out every morning to very small remote clinics and providing mental health services. So they work very closely in with our primary healthcare team. So essentially what you've got is a pilot, a nurse, a doctor and a mental health clinician, and they work as a team like you'd see in a city GP practice, essentially is what that looks like. Very similar, although it might look quite different on the ground. There's some pretty interesting places that we provide service to. My favourite memory of doing that was doing therapy with an 8-year-old girl who was running around an X-ray machine. So that was the therapy room I had for the day. So it does get pretty interesting, the places that you see people. In one other town, it was providing therapy behind the bar, because the bar was closed at the time. But so it's just really being adaptable in a rural and remote context is a really big thing. And then we've got our drought wellbeing service, which is, I guess, to a large degree, really producer focused, but really anyone that's impacted by drought. But that has meant there has been a large producer focus there, and that's been involving a lot of mental health promotion. So one of the things that we've always been concerned about is that producers generally have a very low uptake of mental health services and quite a high suicide rate. So what we've really been trying to do there is promote mental health, and we have had a big advantage in terms of we've got a very respected brand with that audience. So if you imagine if you're off a property, it's very likely that you've used one of our planes to save one of your family's lives. So you do have that respect immediately, and that's been really, really helpful in terms of if they're going to talk to anyone, they're probably going to talk to us in terms of the trust is built. And that's one of the most amazing things actually about the service that I was talking about previously, the fly-in service, was that when that first started, I thought it would take a while to get off the ground. I thought it would take some time, but it filled up remarkably quickly. And I think really what that was is that, all those connections were pre-established. So you had, nurses, pilots, doctors, all knowing that community and then recommending someone. So that trust was already built. And I guess, so I hope that gives you a bit of an overview of sort of the sort of things that we do. We also do training, sort of mental health first aid style training, whether that's formal or sort of shorter workshops in terms of if a particular community or station's got a particular interest that they want to talk about. Might be depression or anxiety, it might be stress, it might be even conflict. So there is quite a large sort of public education angle as well, which I think has been really useful too, just in terms of, the leaving skills on the ground, but also just them getting a feel for the person, whether they're actually comfortable going and then talk to the person. So you're much more likely to have a conversation with someone who's had the chance to sort of check you out first in that way, in a more sort of public setting. So they're the kind of things we do in mental health in Western Queensland for the RFDS. Obviously on the other side in room one, you'd be probably hearing about the Cape and the Northern Service. And that's quite different to Western Queensland. So you're essentially flying people into small communities, a lot larger Indigenous population. Really cultural considerations are really important in the far north team. Look, that's true for us on the western border particularly, and as we go up into the Gulf, but you'll certainly see a greater focus up on the Cape. And then we've got Headspace in Cairns as well, that's obviously focusing on the younger people.
Yeah, so it's a lot of services provided in varied ways. And as you said, Tim, trust and that and connection is so important. I loved what Joe said about, just yell out from the car, just adjust to the circumstances and to your audience. Ebony, you had your hand up.
Yeah, thank you. I just couldn't resist the opportunity to give a plug to rural generalism with advanced skills in mental health. It's a really great mix. And, a day for me looks like a mix between general practice and therapy time with my individual psychotherapy patients, to seeing patients in ED when they're having behavioural crises or mental health crises, or something, having a baby when birthing is closed in Cooktown at the moment, or whatever else walks through the door, plus managing the ward, plus being on the phone to all of the communities around, and sharing that with a group of my colleagues. So you kind of get that whole sense of the breadth of medicine, and the sense that mental health, I guess, skills in mental health and addiction medicine allow you to do that so much better. Just because you can communicate and you can understand that full range, and you still have to be able to sew people up when they cut themselves open with something, and you still have to be able to deal with the bleeding pregnant woman. You still have to be able to deal with the car accidents and all that kind of stuff, but you get to do therapy as well, which is just like the best thing ever. So it's a really nice mix for the medical students. I couldn't resist to say, please, we need more of you.
So maybe mental health is the sort of glue that binds all the rural generalism skills together. We've got a question from Alex. He says, thanks for all the sharing so far. I'm wondering, as an international student, do you feel like there will be a difference in reception to non-Australian mental health practitioners, or what additional factors should be taken into account? Who would like to pick up on that?
Well, look, I'm happy to do that. So look, we've actually got people from all over in our mental health team with really good reception. One of the things that people often are concerned about is that rural and remote will involve more prejudice and things like that. It doesn't seem to be the case at all. We've had certainly people from all over the world working for us, and really, they've been exceptionally well received, everyone. I've never seen that be an issue. I've seen it, people be very concerned about that going into community, but I actually haven't seen it in terms of, people who have experienced that directly, talking about it being, there are issues sometimes, like there are in the city as well, but I haven't seen it be a bigger issue. It's more of an idea, I think, than it is a true issue. So while those challenges that sometimes do exist, I certainly don't see it being any larger than when I was working in sort of an urban context. I didn't see it any more often. And I think the other thing about small places is that people are really, the other thing about some of these towns, people from all over anyway. And that's it. The other thing is that you've got a large backpacker population moving through. So a lot of your bar staff are from all over the world. So it's not like it's one group of people. I mean, remote Queensland's got people from all over the world. So certainly I wouldn't be concerned about that.
Thanks,
Can
Tim.
I just add, Tim? I completely agree, and I've certainly always had a lovely welcome. And when I did some postgrad study in Indigenous mental health, one of the questions I was quite interested in is the qualities of a non-Indigenous clinician that makes them thrive, because I just kind of saw some people would do really well and others weren't. I thought, I wonder what it is. And there are some studies out there, mostly from psychology, and it was all about your personal qualities. So it's about being adaptable and flexible and humble and down to earth, and it was about your approach. So I think, irrespective of your background, it's about how you go how you go about approaching your care when you get there.
Thanks, Sarah. I just want to spend the last few minutes, unfortunately, we're running out of time, but I want to introduce Megan Gomez. Megan's the founder and director of Rural Health Connect. And I'm going to let Megan talk about what Rural Health Connect is. We're very excited to have her talk with you tonight as a creative initiative to delivering psychological services to the bush. Megan, I'm going to let you give an overview of the work you do and how you got there. Thank you.
Thanks, Meredith. Thank you. Hi, everyone. just quickly, because I know we don't have a lot of time, but Rural Health Connect is an online platform that links people to psychologists. So I'm not I'm not medical myself. I've sort of just fallen into this and have been doing it for a long time now. So I've sort of got a different perspective on it all. But we've also got GPs on the platform just to prepare mental health care plans for people who can't access a GP locally. And we really focus on working with people who can't access mental health services otherwise. So it's quite a privileged position that I'm in that I get to be sort of the conduit between the clients and the psychologists or GPs. And we work with people across, I guess, a wide spectrum from just people experiencing situational stress to more complex conditions where we might be working alongside mental health units and that sort of thing. Almost universally, it's just a real pleasure to sort of spend some time with them, just to reassure them about the technology and the software. It's done over video calls or phone calls, but it's pretty straightforward to use. And so I think just like spending a minute or two just explaining what to expect is enough for the people that end up with us. They've obviously chosen to be referred to us in the first place. And then knowing that if there is an issue that they can call us and we can help sort it out, I think allows people to go forward with confidence. Yeah, I mean, it's great just to know that people who have often been seeking help for a long time are then able to access it and really be linked into someone who might suit their particular needs. So that's what we do. Telehealth is definitely not a solution for everyone, but we've found that a lot of people have really embraced it. And what we've also found, which may or may not be relevant to you guys now or down the track, is that our service is used by health professionals quite a bit. We do a lot of disaster recovery work in bushfires and now also floods. And what we've found with the bushfires and likely also with floods is that people who sort of get fatigue after from dealing with just the recovery process for a long time want to talk to someone, but they're all so busy and there's likely a reluctance possibly to speak to their colleagues or people they're working alongside. So often they'll turn to us. So if that does suit anyone's situation at any stage, then we're here. But, you know, equally, we're just one of many services that are available.
Thanks, Megan. That's a great overview. I think one of the things that really got my attention was the access that, in terms of payment. Do you want to just quickly run the audience through that?
Yeah, sure. So we're bulk billing for anyone who needs it, which is most people who comes through. What we do have though is an optional payment, gap payment of $20 where people can elect to pay that, and that just makes the whole process more sustainable for the practitioners on board, or they can elect to pay the full fee and get the rebate. Some do choose that. I mean, increasingly people are choosing to pay the gap payment, and it may be that we introduce, a couple of options so people can select, some people might select a higher one. So what we're really trying to do is provide a service that can bulk bill those that really need it, and there are many people like that, but then we really respect, I mean, we're eternally grateful to the psychologists who work with us, and generally they are lovely, altruistic, they're just amazing, and we have a very close relationship with them, and just want to provide a really sustainable model for them too. So it's just about finding the right balance in how we coordinate things, and that will probably be a work in progress forever, but I do feel that we're sort of getting there, and we do other work too, like with PHNs and contract and that sort of thing, where overall we think that we're getting more sustainable, if not the most lucrative option in town.
Thanks, Megan. We're just about to go back to the main room, but I just think it's an important point about, the affordability of mental health care. Obviously it's very hard for people to access, especially as you were talking about with so many natural disasters, and added on, COVID, the need for accessing mental health services both in the bush and in the city is greater than ever, but it isn't always affordable. So, thank you for taking us through your service, and it's a social enterprise, so that makes it even more special. And I just want to open the floor up to the other speakers to just provide us with some of the things that you put in place for your own mental well-being. What are the things that the other speakers do to keep themselves safe and able to practice?
I'm happy to go first and be vulnerable out there. Thanks, Izzy. That was really, really helpful. And I agree with what the others said, that the more we talk about this as every day, the more people see that we're not exempt from things going wrong, the more open we're all going to be. For me personally, I remember a friend who burnt out, and we all saw it coming for 2 years before she saw it, and we tried to talk to her about it, and she couldn't see that she was burning out. And that was a real lesson for me early on. When I've worked with really disadvantaged youth that are living on the street, that child safety hasn't given any housing to, that have had really terrible backgrounds. And I actually go into therapy when I work with those groups of people, so that I don't, be traumatized by the stories that I'm holding. So that's always a number one for me. If I'm working with really traumatized populations, I'm not scared of having my own therapy. And the other one for me is having some really good friends who I trust, that when they say to me, hey, I don't think you're travelling well, I then have a plan that I follow, and that's an agreement we've come up with each other. And that's a lesson that I learnt from my friend who burnt out. But generally, just everyday self-care is the same things I tell my clients. Mindfulness, I do swimming for my movement. I find that really therapeutic. Walking, I connect with friends quite regularly. I really love that catch up. Even during COVID, we'd do it virtually. So all those everyday things I tell my clients to do, I do for myself. And when I don't do it, I have people that tap me on the shoulder and give me a kick.
David, I know that you have taken smell the roses literally. Do you want to tell the students about what that looks like in your life?
Yeah, I was listening. I think it's different for everybody. I'm a real introvert, so for me, I need to do things that where I'm by myself, and I guess I found kind of by accident, and I'm kind of sound old, but I really enjoy gardening. And so for me, it's being outside and you're just kind of spending time digging things up and listening to the things around you and smelling the plants around you. I would say, as much as I am introverted, getting involved in some community groups. I think it's useful to be involved with things outside of work and meet people that have just other interests and other things to talk about than just work. It just helps me. And I became involved with the local race club here, and I think Meredith's hinting at the fact that I decided to plant a rose garden at the race club, which is I did quite a few years ago now, and that's still something that I have to prune every year, which is due this weekend roughly. But we've got a grasshopper plague at the moment, so I get let off, because if I prune them now, all the new shoots will get eaten by the grasshoppers. So I've got to wait till they go. At least that's what I'm telling people.
Yeah, it's a fantastic story. I love the way that you do that, David. It's just, it's peaceful, and gardening is rewarding. You get results. Anybody else would like to share what they do in terms of self-care?
Meredith, I'm absolutely a fan of gardening. I'm never happier than when I'm on my ride-on mower. But the other thing that I think that is really important, I think we do it quite well in mental health, is supervision, because it's so important to be able to have a space to reflect and talk through cases and work out, how you can manage some of those emotions and manage the experience so you don't take it home. And I think that that's something I'll probably always be working on, but having some strict boundaries around discussing things and then leaving it in the workplace. I think that's really healthy for burnout.
Yeah, I think that's excellent advice. Ebony, you were, when we were in the breakout room, you very beautifully explained your own personal journey into your specialty of mental health. But what do you do? Because I know that you have an extremely busy practice, and you're also a mum and a wife and a community member. What do you put in place?
Yeah, thanks, Meredith. So I guess there's a whole range of things, and I have burnt out a few times over the last couple of years being a rural generalist when studying for exams and 2 kids under 5 and all those things, 100-acre property. And yeah, I guess the most important thing for me is that I do try and achieve balance, try and have enough time off. And when I do have time off, that I'm actually disconnecting from work. So I'm out camping, or I'm out at the beach, or doing craft projects, or spending time with the kids. I also like gardening. I have a huge range of indoor plants. That was a passion I discovered over COVID when I couldn't go anywhere or do anything. Before that, it killed everything. So thanks, COVID. Yeah, and just, I don't know, just doing all the things that you tell your patients to do. It's actually really hard not to do those things when you spend all day telling people, sleep well, eat well, make sure you're mindful, make sure you have time for connecting, time reflecting, supervision. I've had my own private psychotherapy for the last 7 years, once every 2 weeks that I pay for. And I consider that clinical supervision, and I would do that again 1,000 times over. That's been well worth its weight in gold, I think, for the benefit that I've received out of that. Not just in terms of having a safe space to actually discuss that, but when you're dealing with mental health patients all day, you invariably bring up issues from your own life just by what you're talking about, and you might be triggered and whatever. You need a space to work through that and understand what the impact of whatever's going on for you in your work life is on your home life, and your home life on your work life, and so on. So I would shadow Sarah and David's thoughts about supervision, and Sharon's, as supervision is one of the key things that helps me maintain what I do, especially up here when you're isolated and you're one of, the only GPs that does that work. No one else kind of gets that and gets the emotional load and the mental load. People don't really understand unless they're doing therapy themselves or taking on those stories. So I think, whatever you need to do to invest in your mental health, you can't look after anyone unless you've looked after yourself first, is my number one rule.
Yeah, I think that's a very good point to end on. Thank you, Ebony. It's time to finish up, but I just want to make some closing remarks to say that, today mental health and wellbeing is an accepted part of public discourse. However, the social stigma surrounding mental illness is in families, communities and workplaces is still widespread. Tonight we heard from speakers who've navigated these constraints. And by doing so, they've created pathways for people living in the bush to move forward. And it's our hope that what you've heard tonight will remain with you as you travel your own personal and career journey. And if you're keen to learn more about mental health, the Health Workforce Queensland Student Hub has a list of resources that were generously provided by our speakers. And I just want to ask Wendy, could you please move down to the section about Yarrabah? One of the speakers here that was in Breakout Room 2, Joanne, she has an amazing story about going out to Yarrabah to do a student placement and is now working out there. So there's some footage about the community, but I would love you to have a look at Yarns in Yarrabah if you want to have a feel-good. We've been talking about trust and connection, and just being happy to be with one another. Please watch Yarns in Yarrabah. It's delightful. It's and that page is there for you as students. We're happy to receive, if you've got things that you want us to put on that you think are useful, please let us know. There's an email address there for you to send your resources through on. And finally, I'd like to sincerely express my gratitude to all the Go Rural Virtually speakers tonight who so freely shared their time and experience with us, as well as the Health Workforce Queensland team members who made tonight possible. Thanks everyone, and we'll see you at the next Go Rural Virtually.